I could just have your attention for a second. Dr. Feingold's on his way, so we're going to start the meeting officially when he gets here. I was a student of his. My name's Jeff Murray. I was a student of his about 30 years ago, and I'm going to tell a story about him when he visited us in Iowa one time. So Dr. Feingold came out, and he's never hunted before. Iowa's a big hunting state. We do a lot of duck and pheasant hunting. So he asked if he could go out duck hunting with us. So I took him out with myself and him, the geneticist. I'm a pediatrician, and then a surgeon and a pathologist. And the duck blind that we had was pretty small, so only one person was able to get up at a time and take a shot. So I went first, and pediatrician. So I stood up, and a little duck appears at the horizon, starts flying towards us, and I started talking about, well, maybe that duck has children, and children are really special, and what if they have a family? And as I was kind of talking, I kind of lost track of things. The duck flew overhead, and I didn't even get a shot off. So everybody sort of looked at me with disgust, like, come on, we're out here to hunt. So Dr. Feingold was next, so he got up, and he's a geneticist, as you know. So again, little speck appears in the distance, and he starts going through the differential diagnosis of all the different kinds of ducks. So he's talking about blue-winged teals and shovelers and widgeons and all the different possibilities and varieties of ducks. And as he's talking, same thing happens. Duck whizzes by. None of us get a shot off. So next up is the surgeon. So once again, little speck appears off on the horizon. And as soon as the speck appears, surgeon pops a shot, speck falls out of the sky. He turns to the pathologist and says, go see if that's a duck. Dr. Feingold.
I don't know what you said, thank you. I just found another risk factor for a heart attack. A 4-car accident on the expressway getting here. I started home on the Cape at 6:45, and here I am. Well, good morning. Welcome to the symposium, which is sponsored by the Genesis Foundation for Children, in association with the Division of Genetics and Genomics at Boston Children's Hospital. The main purpose of this symposium is an educational one, and therefore it's fitting that we have a diffuse group of attendees because the subject matter affects everyone in this room. We will begin with welcoming remarks from the leaders of the 3 groups that are responsible for this symposium. The first one is Dr. Christopher Walsh, who is the Chief of Division of Genetics and Genomics. Chris is also in charge of the Walsh Laboratory. He's concerned about disorders about the brain and the genes that regulate it. Chris is one of the 3 amigos, Tim, Chris, and myself, who helped formulate this symposium. It's amazing, we didn't have one disagreement. So it gives me great pleasure to introduce Dr. Christopher Walsh.
Well, thanks so much, Murray, for that introduction. And I just want to welcome everybody here on behalf of the Division of Genetics and Genomics at Children's Hospital. And I just want to thank all the members of the Genesis Fund, especially Matt Hoffman and the other members of the board and the parents and all the supporters of the Genesis Fund and the Genesis Foundation for making this fantastic symposium possible. And I want to thank all of our distinguished guests and visitors, Tim Johnson and Charlie Gibson and Jeff Murray, who've come a long way to come here, and as well as David Miller and Robert Green, who have traveled not quite so far to be here for coming to make this event possible. And of course, I just want to thank Murray. I mean, this symposium is in many ways an embodiment of him. The idea of bringing together the best new science, but also communicating that to a broad audience and bringing together so many different people from diverse backgrounds and interests into a common room where we can learn from each other, where the scientists can learn from families, and hopefully families can learn from what you hear this morning. And I think, like I say, that just really embodies who Murray is, just a very, very unique individual with that ability to travel in the most obscure areas of science and genetics and medicine, as well as being able to communicate it to a broader population. You know, a lot of people that may hear Murray on the radio, you know, might not be aware of all the, you know, really tremendous quiet work that he does privately with families and patients. So, you know, this is a very, very special person. Anyway, so I just want to, again, thank everybody, and I hope we have a great day. And why don't we go on with the event?
Thank you, Chris. The next speaker is Matthew Hoffman. Matthew is chairman of the board of the Genesis Foundation for Children. Matthew is overloaded with Genesis Foundation DNA. His father was one of the founding members and served many years on the executive committee. Matthew has worked his way up the ladder from board member to executive committee member to chairman of the board. He is totally dedicated to the Genesis Fund. Matthew Hoffman.
I don't need a box to stand on, so this is going to be a good day. To give you an idea of how excited I am about this morning's symposium, let me just say that, like all of you, I wish I would stop talking already and sit down so we can start the program. But as chairman of the board of the Genesis Fund, I was asked to say a few words, and I certainly was not going to give up the opportunity to embarrass myself in front of so many people. For those of you who aren't familiar with the Genesis Fund, we are a 30-year-old nonprofit organization supporting innovative programs for children with complex genetic disorders. And the programs we support help these children reach their full potential. And those programs fall into basically three categories. The first category is clinical care, most notably the Feingold Center for Children, which is now located at the Waltham campus of Boston Children's Hospital, as well as satellite clinics here in New England, where Dr. Feingold and Dr. Catherine Nowak help diagnose, treat, and coordinate the care of their patients. They also provide tremendous compassion and support for the families of these children. And those families, of course, are vital in determining the outcome and the quality of life of these patients. The second category of programs we support, we call life enrichment, including therapy and the performing arts and other recreational programs for children born with genetic, intellectual, and physical challenges. And these recreational programs might include sailing, horseback riding, swimming, activities that we might on occasion take for granted but provide so much for the kids. And the third category of programs we support is education. This symposium, for example, as well as our Pregnancy Exposure Info Line, which we also call PEAL, which is a free confidential phone service for women who are either pregnant or who think they might become pregnant. And it gives them information on the risk of exposure to harmful substances, as well as giving them information about genetic mutations that they or their partners might be carrying. So before I take a seat, I'd like to just quickly thank a few people. First, my fellow directors of the Genesis Foundation Board, if you don't mind standing up quickly just to be acknowledged. I'd also like to thank the sponsors of this event, which I hope will be the first among many that we hold in this more public forum: Sullivan Tire, Acton Toyota, Bay State Financial Services, Prolacta Bioscience, and Blue Cross and Blue Shield of Massachusetts. And of course, Boston Children's Hospital for this terrific venue and for the relationship that they have fostered, particularly with the Feingold Center for Children. And finally, I'd like to thank all of you for coming. I hope you find today's program thought-provoking. I hope it challenges your perception of medicine and genetics. I hope you ask a lot of questions and continue the conversation with your friends, with your family, with your colleagues, well after you leave here today. Thank you again for coming.
The final welcoming speaker provides for me a really unexpected pleasure. I am going to be the first person to introduce the Chief Executive Officer of Boston Children's Hospital. As of yesterday, Sandra Fenwick became the CEO. Congratulations, Sandra. Prior to that, Sandy was the president of Children's Hospital and chief operating officer. Sandy was the first person I spoke to about having such a symposium, and because of her enthusiastic endorsement, we were quickly off and running, culminating in today's program. I am thrilled that Sandy's maiden speech as CEO of Children's Hospital is to address this symposium. Thank you, Sandy.
Thank you, Murray. I think actually I do need a step behind tall Chris and Matt. Hopefully you can at least see me. Thank you, Murray. It is a real pleasure. As I said to Chris, he said, well, you must be really busy. This is really what you get up in the morning every day to do, to hear the most amazing work that's going on both within our walls and obviously across many of the partnerships and relationships we have. And a great thank you to Murray, because you are truly an inspiration as a physician, as a communicator, as a convener. So thank you so much for bringing us here today. The future of pediatrics, obviously, and all of healthcare can only be forged, in our opinion, through innovating partnerships, where we can break paradigms, where we can join together in a way to think differently so that we can really begin to tackle some of the challenges that we face in healthcare and more even in particularly in pediatrics. The spirit of collaboration is something we pursue constantly at Boston Children's Hospital, and is something we are constantly looking to do with partners across many, many different fields. It's one of the reasons why we combined our division of genetics with our program in genomics at Boston Children's under the leadership of Chris Walsh. And obviously you will hear more about what's coming out of that incredible partnership even within our own walls. Chris's previous leadership in the division of genetics has already led to more than 20 disease-related genes and contributed greatly to the understanding of intellectual disabilities and autism. Now, combined with the state-of-the-art genomics research from Dr. Louis Kunkel and his entire team, they have united and brought together a division that is obviously world-class. We find we will continue to work to find ways to improve both genetic diagnosis in the clinical setting and increasingly build collaborations with other researchers to develop new treatments for children with neurological disorders. We're also building collaborations and partnerships beyond our own walls. One of the most exciting that we have launched this past year is Claritas Genomics. It is a new company formed in partnership with Life Technologies Corporation. We've combined their expertise in software and instrumentation with our own expertise in bioinformatics, genetics, genomics, and clinical interpretation. Claritas is developing breakthrough approaches in genetics and genomics diagnostic testing. And we hope that this will now not only be available to our own patients, but obviously to patients around the country and around the world. Claritas was born from another challenge and another creative collaboration called the Clarity Challenge. It was a first-of-its-kind competition that Boston Children's Hospital and Life Technologies sponsored to try to apply genomics and the genomic insights to everyday pediatric care. We put out a call for submissions to apply genomics to 3 patient cases at Boston Children's that had an underlying undiagnosed diagnostic genetic cause. A year ago, the winner was announced, and an incredible international team from the Brigham and Women's, the Mass General Hospital, and the University of Utrecht in the Netherlands won the prize. Through their analysis, they discovered the genetic root cause of the condition, enabling our clinicians at Children's to provide better care to these 3 patients and hopefully many others beyond that. In a spirit of collaboration, I'd like to thank all of you. I think this is an incredible day for people to not only learn, but to create a growing dialogue, more partnerships, breaking paradigms, and leading to much, much better care for children today and in the future. Murray, thank you again for your leadership and your inspiration. Thanks for coming. I think this is going to be a great day.
Thank you very much. Well, years ago, when I saw my first patient, most of you really weren't even born. Gives you an idea why I have gray hair. Although we were not taught about leeches, as you may think, we were taught at that time, believe it or not, that the body contained 48 chromosomes, not 46. Since then, genetics has come a long, long way. We enter the threshold of today's topic, genomic medicine. Although medical advances such as genomic sequencing are so important in providing the treatment to those who are ill, both the scientific and lay communities don't always appreciate what really makes the healthcare system tick or not tick, and it's money. Our first speaker, Dr. Timothy Johnson, was the editor of ABC Network News and also Boston's Channel 5 for 40 years. He has been called America's doctor, well-deserved. Dr. Johnson has developed a keen interest in healthcare finances. He has written a successful book on the subject entitled The Truth About Getting Sick in America. He is a near and dear friend of mine for over 40 years. He is also a minister, and acting as Rabbi Johnson, he officiated at the marriages of my daughter and of my son. But today, he's going to look into his cloudy crystal ball and talk about healthcare finances and genomic medicine. Dr. Tim Johnson.
As Murray indicates, my job is to, in the context of today at least, sketch a brief overview of the current situation in healthcare reform, the context in which any and all developments in medicine must find a home and live. And so I'm going to just go through a few parts of this book. If you're interested, you can buy it. All my royalties go to charity. And I'm going to give you a sense of what we have to think about for anything new in medicine, and certainly including medical genomics. So if I go to the next slide, the book is divided into 5 chapters. Big question, big problem, big fear, big sermon, big prediction. I won't cover all of that in detail, obviously. The big question, why do we spend twice as much per person on healthcare in the United States as the average per person cost of all other developed countries lumped together? We're going to spend about $8.5, getting closer to $9,000 per person this year in the United States. And if you take Japan, Switzerland, Sweden, England, Canada, lump them all together, the average per person cost is going to be about $5,000. So we're almost twice as much. And yet, as most of you know, our outcomes are no better. We don't live twice as long. So we really ought to be haunted by this. What are we spending that money on? What are we getting for it? I'm going to just skip through a lot of detail this morning and go to one of the big reasons why we spend so much more than all of these other developed countries, but don't have any better outcomes. in my mind, one way to think about it is to say that there are two strong forces loose in our society that combine to form a formula for financial disaster. One of those forces are the unrealistic expectations of all of us as American healthcare consumers. And I've just listed a bunch of C words here that I think characterize what most Americans want when they think they're sick. We want care that's convenient. If we think we're sick, we want an appointment this afternoon with free parking, thank you. We want care that's compassionate, communicative, coordinated. Who wouldn't? But of course, that takes a lot of people and a lot of money. Here's the one that really increasingly I think is the big problem. We Americans have been raised at the altar of high technology. We have come to believe that the newest is automatically the best. And so we want the health care that is on the cutting edge, what we read about in the paper this morning or heard about on the evening news last night, the new breakthrough that'll make the difference. And so we insist on that when we now go into our very convenient health care. And of course, as it turns out, we Americans want it to be cheap or even better, cost-free. We'd like somebody else to pay for it, our employer or the government. I've often mused that one of the reasons we're so uptight about co-pays, for example, when they go from $10 to $12, is that after all, we are now being asked to pay for something we didn't want in the first place, right? We didn't want to get sick, and now we have to pay for it? That just doesn't seem subconsciously right to us, I suspect. So I'm going to skip through to the drivers of healthcare, the other side of this formula or this equation. And again, summarizing very quickly, if you look at the first three, doctors, hospitals, drug and device companies, we often refer to them collectively as the providers. They're the ones who take care of us and provide the things that help take care of us. And as most of you in this room know, for decades, the model has been the so-called fee-for-service system. We basically say to all these people, the more you do, the more you produce, the more you're going to make. Often referred to correctly, in my judgment, as a very perverse incentive. And so we all know that we've got to do something about that payment system. Very complicated. How do you change the culture of fee-for-service? You read the papers, you hear the news, you know all the discussion about bundled payments, all kinds of ways to try to figure out how to pay for outcomes and results, rather than simply saying to this medical industrial complex, the more you do, the more you'll make. That phrase, by the way, was first coined by Arnold Bud Relman when he was editor up the street of the New England Journal of Medicine in 1989, playing off of Eisenhower's famous phrase, the military-industrial complex. So we've got this driving force that's matching up with the expectations of America for the newest and the latest, and to me, that's a formula, if we can't figure out how to control it, for absolute financial disaster, which is why, until the last 2 years, for reasons not totally clear, the inflation rate for healthcare has been 2 to 3 times the general inflation rate. It goes like this: general inflation, formula for disaster. Now, the last three, I could talk for hours about insurers, and obviously this week that happens to be a very important topic. I'm going to simply say that the cost of insurance industry in this country, the actual administrative costs, if you look at apples and apples, it's about 11.3% compared to 1.3% for Medicare, which is a single-payer system, unlike, of course, the very complicated private health insurance industry in this country. Malpractice, a whole other subject. Every other developed country in the world has some kind of a no-fault system. We're going to have to get there. But I do want to say a word about the media for obvious reasons. When my eyes were open on this subject, it occurred in the 1990s, and many of the more mature people in the audience today will remember this. Some of the leading breast cancer experts in this country started talking about using bone marrow transplant for advanced breast cancer. And these were top-notch people, the recognized names in the field. And so we in the media all started to interview them, put them on television, put them in the newspapers, and they were saying, you know, in our practice, we're starting to have some really good results, we think, with bone marrow transplant. And very obviously, the American public, loving the cutting edge, started demanding this treatment. Their insurance companies wouldn't pay for it, saying it was experimental, they would get sued. And so we had this huge growth of a new industry of technology, namely bone marrow transplant for advanced breast cancer. Finally, after about 7 years, in 1999, at the annual cancer meetings, the ASCO meetings, there were 3 definitive papers presented showing that bone marrow transplant for advanced breast cancer was no more effective than ordinary standard chemotherapy. So we stopped doing it almost overnight. But in the meantime, we had treated how many? I don't know, hundreds of thousands, probably into the millions of women, not only at a great financial cost to the healthcare system, but at a great personal cost to these women in terms of terrible side effects. We do that all the time in this country. We churn out new technology, it gets loose into the system, we promote it on the news, and we demand it as consumers, and the industry is more than happy to supply it. So we have this formula for financial disaster that really is driving up costs to what I think will be an ultimately frightening point of bankruptcy. The big fear, I'm just going to say a quick word about it, the federal government. Americans are very concerned, understandably, about the role of the federal government in healthcare. I always ask lay audiences to think of an industry in this country that is very competitive in the private marketplace, but heavily regulated to the great benefit of us all. Airline industry, think about it, think about it. Aren't you glad when you get on a plane at Logan or Butte, Montana, or anywhere else in the country that it's the federal government that insists on standards for inspecting those planes and for recertifying the pilots, that we don't leave it up to each state behind smoke doors in the legislature to decide how often they want to do that? And which is why, of course, the airline industry has such a superb safety record. And tragically, why the healthcare industry, which does not have that kind of enforced federal standard. Institute of Medicine many years ago said we have 100,000 deaths every year from medical errors. I'm sure the number is lower now, but it's still in the thousands, many thousands. So I could talk again for hours on this, simply to say that we have to figure out a role for the federal government to level the playing field in terms of safety and competition. Every other developed country has done so. In my book, I describe the example of Germany, which is a very interesting example, many others to look at. I'm going to skip through all of this here and go to the big sermon, which is simply to say, one study recently showed 45,000 Americans die prematurely every year for lack of health insurance. I don't see how anybody can call themselves pro-life. How is it possible that the richest country in the world is the only country that does not have universal health insurance? How is that possible? What's the difference between health protection and fire and police protection? Don't you have to have all three to pursue life, liberty, and happiness? Enough of the sermon. The big prediction. No industrial country, no developed country will be able to do everything for everyone at every age that modern medical science might dream up. We're all going to have to make some tough choices. Now, here's where genomics gets kind of interesting. A caveat. What if we actually someday could figure out exactly what goes on with cell growth out of control, the common denominator for all cancers, and could attack the problem right at that level? Would we then eliminate all the screening, diagnostic, treatment stuff we do with cancer? What if we could figure out right at the very basic genetic level what goes on with atherosclerosis and eliminate the costs in industries surrounding the treatment of arterial disease? Maybe you guys are the answer to all of our problems. But until then, we have to think about the cost of genetic testing in a system that is already overburdened and broken. And that will be a challenge that we can address when we get to the panel. Thank you very much.
Thank you, Timothy. Our next speaker is Dr. David Miller. David is a geneticist in the Division of Genetics and Genomics here at Children's Hospital and is a member of the Harvard Medical School faculty. Professionally, Dr. Miller is a bit unusual in that he not only sees patients, a clinician, but he also runs a clinical chromosomal laboratory. David has the difficult assignment of explaining genomic testing, specifically whole genome sequencing and whole exome sequencing, to a diverse audience. David, you need to straddle the fence of making it understandable to the lay public without boring your scientific colleagues. I'm certain you can straddle this genomic fence. Dr. David Miller.
Thank you very much, everybody, and I appreciate the opportunity to be here today to speak with you all about this subject that I find very interesting, fascinating, and challenging. And then the other big challenge I have is to follow up such a great talk by Dr. Johnson. But I do want to tell you before I start, as a full disclosure, that as Sandy Fenwick had mentioned, that the hospital's genetic testing laboratory has now become part of a larger entity called Claritas, and I am a clinical consultant and medical director there. And some of the things, that the testing that I'm going to talk about is done in that laboratory. So I'm going to try to talk to you, because we're talking about genomic sequencing and whole genome sequencing, and maybe we'll talk a little bit about exome sequencing, to try to get you familiar with what those terms are. In some cases here, I'm preaching to the choir, and in other cases, this is new to people. So I'll try to split that difference, as Murray was saying. I'll talk a little bit about how we try to read a genome in various types of genetic testing that we do as a clinician when I'm wearing my clinical hat. And I'll try to give you a little bit of a flavor of the impact of genetic testing in the clinic. I'm not going to be able to resolve every issue that I bring up, and that's something for you to keep track of. If there are things that I go over that you want to hear more about, jot it down and we'll talk about it in the panel. So when I talk to my patients in the clinic, I talk to them about if we're thinking about doing genetic testing, and I try to give them basically the overview that I'm about to give you. I talk about the fact that we all have genes. We all have genes located on our chromosomes, and we're all a little bit different from one another. So this is a picture of a genome in the form of chromosomes that you're looking at under the microscope. And as Murray had already mentioned, we have 46 chromosomes. You notice that they're paired up, so we get a copy of each chromosome, one from the mother and one from the father, to make a full set. And then within those chromosomes are long strands of that molecule that people I'm sure have heard about called DNA, which is made up of these 4 letters. And so basically the chromosome is just a coiled up, springy thing of information. I try to help patients understand it in the form of this analogy, that a gene, because it contains information that's important to the body and important in disease, is like a book. It has a lot of information, it's written in letters, and it means something if you can decode what's in that, if you're able to read that language. And so a chromosome is basically just a shelf of library books. The genes are lined up on the chromosomes. And so I think of the genome as the entire library. You can think of 23 shelves of library books, and you have 2 sets of every book because you have 2 sets of every chromosome. And altogether, we have about 20,000 genes, 25,000 genes. There's different estimates. There's actually probably more than that, because we have constantly new discoveries about what really it means to be a gene. And all of that is made up by about 3 billion letters of DNA. If you do the math, if you knew how much DNA, how many letters are in an individual gene, what we'll get to is the fact that a lot of those letters of DNA are not actually the genes, and I'll talk about that a little bit in a minute. So when we're talking about genetic testing that we would do in the clinic, one type of testing that we do is to look for big chromosome changes. We call that a karyotype. It's looking at the chromosomes under a microscope. And for example, in this karyotype, it shows that there are 3 copies of chromosome 21, the cause of Down syndrome. So when we see a big change like that, it's easy to identify under the microscope. What we've learned about over the last 10 years or so is that there are a lot of smaller chromosome changes that are too small to see under the microscope. And those can include extra copies of a gene or many genes, or missing copies. We call them chromosome deletions or duplications. And we have a test called a chromosome microarray, which could potentially detect an area of missing chromosome that might contain a few books or genes. So this is what the information looks like when we do chromosome microarray testing in the laboratory. And each one of those little dots is a DNA probe that detects the amount of every part of the chromosome that's present. And the black area means there's the normal amount, and this area means there's extra copies of those sequences at that part of a chromosome. And this has been a really interesting area of development clinically over the last 10 years because we used to not be able to figure out the problem for a lot of our patients, the cause of the problem, when they had some type of chromosome syndrome, because we just didn't have the technology to detect it. And this newer technology has enabled us to find the answer for our patients in a lot more cases than we used to. So the next thing that I'll talk about then is DNA sequencing. So right now I kind of started at the big level of missing sections of a chromosome. Now we're getting down to individual letter changes, because a lot of genetic disorders are caused by individual single letter spelling mistakes within genes. And in order to do that, we need another technique called DNA sequencing. So we have, each of us, out of those 3 billion letters of DNA, we have about 3 million spelling changes that are different from one person to the next. There's a lot of variability, and that's why we're all a little bit different from one another. Some of those don't cause disease, and some of them do. But regardless of whether they're disease-causing or not, if we want to find those, we need a way to detect them. This has started out with the older technologies as single gene tests that we can use in the clinic. So we have a catalog. If we have a particular syndrome that we suspect, we could order a single gene test to basically pull a book out of the library and read it from cover to cover and look for a spelling mistake. With the advancing technology to do sequencing less and less expensively, we have the option to do multiple genes at a time, where we can say, well, we're not sure which gene it is, but it's in this kind of a, this group of genes that we all know creates a heart problem, and this patient has a heart problem, so we want to check 50 genes that are related to heart malformations. We have that capability now in some cases to order multi-gene panels. Where this is now moving, because of the declining costs of sequencing, is to think about, well, maybe we don't need to think ahead of time, or maybe we can't even recognize which type of genes to look for. We'll just sequence all the genes at the same time. That's called a whole exome sequence, or sometimes we call it a whole genome sequence, and I'm going to explain what I mean by the difference. So this is letters of DNA on a chromosome. The genes are put on the chromosomes in basically segments that are separated by parts of the chromosome that are not going to be in the gene eventually. So what I mean by that is when you make a gene, when you copy a gene out of a chromosome, there's basically 3 chapters in this gene or book analogy. And what you do is you copy those out, splice them together, and that's the gene that actually works in the body. The other 99% of all these sequences outside of here are what we used to call the junk DNA, because it's not the part that's in the book when we're doing a gene sequencing test. We called it junk DNA because we didn't know what it did, but we actually think that it does a lot of turning the genes on and off, and it's actually very important. We just have a limited understanding of it right now. So if we talk about doing whole exome sequencing, we're talking about sequencing that 1% of the genome that are the sequences in the books that make up the genes. If we talk about whole genome sequencing, we're talking about sequencing everything, including the 99% of the genome that we're not quite sure what it means right now. Whether we're doing exome or genome sequencing, the questions that you might have if you're not part of this, the medical community, is why would we do it in the first place? We do it in part to try to answer the question, why does this patient have the particular medical symptoms that they do? We sometimes will be able to find a genetic change that's related to other complications or potential complications. So for example, in some cases we might find that a patient has a chromosome change that we weren't able to recognize on a clinical basis. Once we find that out, we look in the literature, we see that 20% of the patients that have that chromosome change have congenital heart defects. So maybe we need to have an echocardiogram to check and make sure that there's not a structural problem in the heart. We use it to try to guide our choices in caring for that patient. Ultimately, we'd like to be able to use that information to have better treatments for the patients. So as an example, it could be choosing a different medication for a patient, It also might involve surveillance, as I mentioned here, looking for other associated problems. And if we can find the answer for patients, we might be able to give the family information that's related to family planning and prenatal testing, for example. So those types of impacts on medical management that I just described are something that we've tried to look at with the chromosome microarray testing, and I'll just try to really briefly describe that to you. The things that we considered that would possibly help us in terms of clinical management are things that would help us make an appropriate referral for the patient based on the genetic diagnosis, order some surveillance testing like an imaging study or another lab test. And so in the study that we did, we looked retrospectively at about a year's worth of patients that had been tested by chromosome microarray. About 7% of those patients, it was the diagnostic yield or positive rate of results, about 7% that had an abnormal result. And when we looked at those patients for whether that influenced how the patient or how the clinician then managed that patient, we found that in a little bit over half of the patients, there was some type of a decision that was different based on the results of getting that genetic test. That doesn't demonstrate that we changed the outcome for that patient, but it shows that the information was used in guiding clinical care. Now, we might also think about the value or utility of the genetic test in the form of diagnostic yield. How often are we able to get an answer, even if we can't change the management of the patient? As I mentioned, for the chromosome microarray, in the one study that we did, it was about 7% in that year. In some cases, depending on the mix of patient population, it can be as high as 10 to 15% in the larger studies that have been done. As opposed to some of the early preliminary reports for exome sequencing, where people are reporting that in about 25% of the cases, they may be able to find an answer for the cause of the genetic problem in that patient. So now I'm going to, after showing that contrast of perhaps there's a little bit increased yield of doing exome sequencing over chromosome microarray testing, I want to just end by talking about the pilot program that we've had here at Children's Hospital for doing whole genome sequencing on 10 patients that we selected by a committee-based process of specialists from throughout the hospital. We tried to select patients that have a variety of different medical problems. We actually have 2 patients that were contributed by Dr. Nowak from the Genesis Foundation Clinic as well, that I'll tell you about. And when I call them trios, for people who aren't familiar, that means we had sequencing done on the patient and both of their parents so that we could compare and look for genetic changes that were new in the patient as compared to the parents, for example. We had selected cases that we suspected would have some type of genetic cause based on the family history or the type of symptoms that they had, but also that they had had extensive workups already done, had had other testing, and had had no answer that was available at the time. I'll just tell you about one patient as an example, and then I'll give you how are we doing on time, Chris, do you know? Okay. Okay. So I'll tell you about this one patient, and then I'll kind of give you an overview of the 10 patients altogether. This was actually one of my patients who I saw with several other specialists, but I've seen him as well. It was a little boy who had growth delay. He had some hormonal disorder, and we didn't know the cause of it. He had had a lot of workups done, and we were still very curious because otherwise there was no family history. He had 3 older brothers, all of whom were unaffected, and the parents were unaffected as well. But hypoparathyroidism is a hormone disorder. He had problems regulating the amount of calcium in his body. It was affecting his growth. He was very short compared to his family. He had hearing loss and developmental delays. And I'll just kind of briefly give you an overview without going into this list in detail. This is all the workup that he had had done clinically prior to considering whole genome sequencing. And the first 5 things on this list are various different genetic tests that were done on him So you can think of it again like this is sort of an a la carte menu of genetic tests that we had, as opposed to if we did a whole genome sequence, it's kind of like trying to, have the whole menu all in one test. So he had a number of things done, and this would add up to several $1,000s worth of individual tests that were done prior to having whole genome sequence. All of those were negative. When we did the whole genome sequence, it jumped out at us pretty quickly, so there's a mutation here. Actually, all these mutations in this list are ones where they exist. It's a spelling change in the DNA that exists only in the patient, not in the parents, in almost all of those cases, and especially in this one that I'm showing you here. And not only is it a brand new genetic change that's not in either of his parents, but it's in a gene that's very important in the development of the parathyroid gland. So it jumped out at us immediately as the explanation for a large number of his symptoms. And as a brand new change, it was a change that causes a very significant difference in the sequence of that gene, so that we would predict that the gene's not working properly. It was one that's never been described before in the literature by anyone else. So it's sort of a new discovery, but at the same time it's in a gene where we understand the role of that gene, and then we can predict that this is the cause of the patient's symptoms. So that's good. That shows that we've demonstrated diagnostic yield for that. If we talk about whether, you may ask me about whether that's changed the management of that patient. It has the advantage, for example, that now we don't have to do a lot of other testing to continue to try to find a diagnosis. We've been able to explain his symptoms in that way, and it's helping his endocrinologist to make sure that he's got the right focus in terms of his treatment of the patient's symptoms. But it's hard to demonstrate outcomes for doing these genetic disorders, and I'm just going to throw this out there so I can hope we can come back to it in the panel discussion. And I think part of that problem is because this is a very rare disorder, and sometimes when you're talking about looking at outcomes, you have to do studies about comparative effectiveness and take multiple patients who have that same disorder and treat them different ways and see how their outcome is different. So I want to make a plea to say, let's talk about that in the panel discussion. If we're comparing outcomes research in genetics, it's a little bit different than in disorders that are very common, like asthma and heart disease and that sort of thing. But just as a way of looking at outcome in terms of diagnostic yield, I want to summarize, and I'll finish up with the next couple of slides, summarize the outcome of the diagnostic testing that we did by whole genome sequencing in our pilot program. We basically had a 50% rate of being able to find an explanation by using this technology in this selected group of 10 families. So we had our patient with the hypoparathyroidism. We had another patient with autism and intellectual disability. We had a patient with what's called a paroxysomal disorder. We had a patient with a neurological disorder called ataxia, which causes muscle problems and balance problems. And we had a patient with a dilated cardiomyopathy, which is a heart disorder. And I think that one of the themes that came across to me in looking at this is the patients where we were able to find a diagnosis had symptoms that were fairly distinct and able to recognize those symptoms, and also that we had to have some knowledge of the types of genes that cause those symptoms in order to make that connection once we do the genome sequencing. These are the 5 cases where we had basically negative results, where we weren't able to come up with a specific answer. In these cases, they had distinctive phenotypes. So we had a patient with cardiomyopathy, a patient with another neuromuscular disorder, 2 patients with cancer in families where there wasn't a large family history of cancer, but these patients had multiple tumors, which made us think that they had some type of cancer susceptibility, and a patient with a problem with the drainage of fluid in the chest. and we weren't able to come up with specific answers in these cases, in part because the genes that cause these symptoms are not all as well known. For example, in one case with this cardiomyopathy, there's a lot known about those genes, but we found changes in a gene that's never before been related to cardiomyopathy, although might be. So there's some hints and suggestions that there may be answers there. We're kind of, because we're sort of pushing the envelope with the amount of analysis that we're doing, we're kind of on the edge of our ability to make clear distinctions. But the take-home message was in 50% of the cases we were able to find an answer, which I think is a big improvement over the previous technologies. And I think it makes us very hopeful that this will be an improvement in the way that we are able to diagnose genetic causes for these patients. So I want to finish by acknowledging the fact that I'm telling you about that pilot project, and it really involves many, many people who put a lot of work into it, clinicians from the hospital, from multiple various departments, for both coordinating and participating and contributing patients to that project, people within laboratory medicine, Dr. Platt, who's the chair of laboratory medicine, and others in the genetic testing laboratory who are my colleagues, Dr. Wu, Dr. Shen, for example, from the genetic testing lab, and the Gene Partnership at Boston Children's Hospital, which is an organization to try to foster the understanding and implementation of genetic testing, both in research and clinical care. So I'm going to finish up there, and I think we'll probably save questions till the panel discussion, right? Thank you.
I think that you have to appreciate that 50% diagnosis. These were patients who were followed for a long period of time and never had a diagnosis. When I started, we were making diagnoses in maybe 40% of the patients. That means 60% of our patients we did not know was wrong. So to we old-timers who are having so much difficulty making diagnoses, this is a tremendously great news. Well, now our third speaker is Dr. Robert Green, who is in the Division of Genetics at Brigham and Women's Hospital and Partners Healthcare Center for Personalized Genetic Medicine. This is an offshoot of genomics. Dr. Green was the corresponding author of the American College of Medical Genetics recommendations concerning the reporting of incidental findings, a very important subject, that are present in clinical exome and genome testing. Not everybody has agreed with these recommendations. And this is just one example of the many medical and ethical issues that have been raised by genomic testing. Dr. Green will hopefully clarify all these issues in his 20-minute discussion. Thank you for doing that, Robert.
Thank you very much. It's a privilege to be speaking to you today. Thank you for the invitation, Dr. Feingold and Chris. And I've titled my talk, Adventures in Clinical Utility Along the Path to Genomic Medicine. As David pointed out, there is a lot of controversy about how we demonstrate the clinical utility of genomic medicine. And I'm going to briefly take you through the last 14 years of my work, yes, in less than 20 minutes, and try to share that with you and where I think we're going, which is very exciting. I have modest disclosures for you there. And mostly, we're very grateful to NIH. We have had a number of funding opportunities through NIH that have been very exciting. You're going to hear about a couple of these. So, of course, you can find genetics everywhere, not just in patients. This is Jeep tells us that they are genetically engineered to be brave and free. BMW is a sedan with a genetic advantage, and in case you need to get your car repaired, it can be DNA tuned. And all of this reminds us that the state of automotive genetics if it was not always where it is now. The very first hand-built car was the Cugnot Fardier à vapeur, a steam-driven automobile built by hand, great cost, took great time in 1771. Sort of reminds us of how the genome is created and mapped in the early days. But there's also an interesting story. When this was introduced into England, these steam cars were seen as a huge threat. And a law was passed, an actual law was passed in which someone had to run ahead of the steam car with a red flag waving it in order to protect people from this machine. I'm sure that the analogy to genomics is not lost on you. And the real question as we think about clinical utility is always the balance between benefit and harm. And that's going to be really the theme of what we've been working on. I guess the question also is, where are we now? Are we somewhere, I think, just before the mass production of genomes and its integration into society? I mean, I feel like we're building the Model T factory here. Perhaps Claritas is part of that. But it's a very exciting time, and I think we're about to see genomics launch into society and change society in the same way that mass-produced cars changed society then. Of course, where are we going is anybody's guess. I just thought, just keeping with this theme for a minute, you might enjoy this futuristic notion of the car, entirely grown in a petri dish, special proteins for the transparent areas, special proteins for the wheels, and so forth. Anyway, all this to say, the program that I direct is called G2P, because anything cool has to have the number 2 in it. But what it really is a research studies in translational genomics and health outcomes, where we're trying to talk about how genomes are going to be used with patients, physicians, and public health. Now, if you're familiar with the NHGRI blueprint, there are a sort of categories of science as we move from really basic science and understanding the structure of genomes through the biology of genomes and disease, which many of our speakers and audience members are working in, and then to these elements of advancing the science of medicine and improving the effectiveness of healthcare. So our work is really on this side of the spectrum as we try to take the discoveries of genomics and integrate them into healthcare. So one of the first questions that I think is really important to address and continues to be important to address is genetic information harmful? We know that it can be upsetting. We've all, with our patients, had that experience. But about 14 years ago, we started asking this question using a very specific paradigm of ApoE and Alzheimer's disease. As most of you know, the E4 allele of the ApoE gene does increase your risk of Alzheimer's disease, and there's nothing yet you can do to prevent this or delay its onset. So with that in mind, let's do a little audience participation and see how many of you would like to know right now what your ApoE genotype is to determine some of your risk of developing Alzheimer's disease. Put your hands up way high. Great. The new CEO of Children's wants her genome. I've got a phlebotomist outside, so we'll be taking your blood at the end of the session. Actually, there is a difference between what people say they'll do and what they'll do, right? Anyway, we decided to ask this question a few years ago when it was actually much more controversial to ask it than it is now. And we started something called the REVEAL study, which has continued to be funded through that time. And when we started this study, it was actually quite terrifying because many people believed that we would actually do our subjects great harm. We put in all sorts of safety nets. And we were so concerned about this, we did it like a randomized clinical trial where you're testing a new drug that might actually have terrible side effects. So we actually did a randomized clinical trial and randomized people to one arm with genotype disclosure and another. We've published many articles about this, but just to give you a couple of the highlights, in terms of anxiety, distress, psychological outcome, at least these volunteers, and I stress that they're volunteers, obviously information-seeking people, did not have increases in anxiety and distress. They really appreciated the information. They said they'd do it again. They were happy with it. Even when they learned so-called bad news, they valued the information. They would have given it. They would have given large amounts of money if they had, at least they reported, they would have given that to get this kind of information, something that hasn't been lost on direct-to-consumer genetic testing companies. they actually did things with the information. Now, we've had this notion floating around that genomic information is never going to be used by anybody, but folks said that they were going to change their vitamins, their exercise, and their medications, and they were more likely to say that if they were E4 positive. Of course, there's a dark side to this. People said they'd go online and get unregulated supplements, and we don't always appreciate that. That's not a good side of American medicine. And we were the first to demonstrate that there really is adverse selection based on genetic information, as has been hypothesized and written about in many, many circumstances. People were 5 times more likely to purchase long-term care insurance if they learned they were E4 positive, had increased risk for Alzheimer's disease, than if they learned they were not. And this has not been lost on the industry of long-term care. And as more and more people get this kind of information through direct-to-consumer and other means, it wouldn't surprise me if they start asking you what your genotype is before they sell you long-term care insurance. Now, we've also asked whether genetic information that's traditionally thought to be frightening and confusing can be offered in the context of a doctor's office without the sort of cushion of genetic counseling. We all appreciate, particularly those of us in medical genetics, appreciate that genetic counseling is the gold standard for educating and preparing people for this information, but can it be offered in a less optimal situation? So we created another randomized trial where we sort of had an extended protocol, which is your typical Huntington's protocol with pre-test education, an individualized counseling session, and a much more condensed or compressed protocol where you basically got a brochure, and when you came in to get your blood drawn, someone said, "Do you have any questions?" Pretty much like your doctor's office today. And we were able to demonstrate that there really was non-inferiority of this in terms of distress and other psychological measures, as well as in terms of learning and remembering the information. This basically demonstrates that here's the black line is the Huntington-like protocol with genetic counseling. The red line is, the blue line is a compressed protocol with genetic counselors. The red line is compressed protocol with MDs. And there are differences, but they do not cause a sufficient difference in distress to be of concern, again, in our very limited arena of this clinical trial. We also did a third round of funding in which we did yet another randomized trial where we used this as a paradigm for incidental findings. Now, all of you know that when you do genetic testing of various sorts, and especially if we try to talk about doing the genome, you're going to find things that you didn't expect. So we took advantage of the fact that ApoE gives you some information about your Alzheimer's risk, but people don't actually realize that it also gives you some information about your heart disease risk. So we surprised one arm of the study with additional risk of heart disease. So that's an incidental finding of sorts, even though it's the same gene. And we did yet another randomized clinical trial. And once again, you can see clinically significant levels of distress up here, whereas all of these, whether you were E4 positive or not, whether you learned about the CVD risk or not, you were pretty much down here in about the same level. But there's some really interesting and sort of puzzling things going on with this. For example, here in the blue bars are the people who just learned about Alzheimer's risk. And sure enough, if everybody starts off about here, and if you learn you have an E4 negative, you go, whew, that's a reduction in distress. And if you learn you have E4 positive, you go, oh, that's kind of unfortunate, and you have an increase in distress. Now remember, this isn't a big increase in distress. Clinically significant distress is way up here, kind of off the scale, but it's statistically significant. Interestingly, when we also gave people cardiovascular risk information along with their Alzheimer's risk information, the people who learned they were E4 negative were just about the same. The people who learned they were E4 positive actually had a reduction in their distress. That's puzzling. You learn you're at increased risk for two things, and instead of being twice as distressed, you're half as distressed. Makes no sense, and we're not really sure yet what what causes this, but possibly if you learn about something that you have more control over, or if you just learn about several things at once, maybe it sort of dilutes the impact of the disclosure. And maybe this helps explain why when you get direct-to-consumer genetic testing and you learn about 70 different risk factors, the whole thing is sort of washes out, and there haven't been catastrophic responses, as far as we know, to direct-to-consumer genetic testing, as was predicted when that industry was launched. Now, speaking of direct-to-consumer genetic testing, it's a fantastic new industry that has completely disrupted our vision of genetics and genetic information. It's controversial. There's a lot of concern about people misunderstanding results without the expert intermediation of physicians, but that hasn't stopped them whatsoever. They've gone ahead and been called Time's Best Invention of the Year in 2008, and quite a few of you I know have actually purchased these services, as I have. These are some of my results, and you can see why they criticize them. My risk of ulcerative colitis has gone, according to my genetic testing, from 0.8% to 1.1%. That's a 50% increase. That's huge, or not, because it's gone from a little over 1% to a little less than 1%. And therein lies, I think, a lot of the concern about this industry. But, you know, there's also some other things that might be a little bit more relevant to my health. I happen to be one of 5% of Caucasians. That means about 6 of you. Who is factor V Leiden positive, and sure enough, that means that I have an increased clotting. I'm actually standing up and walking around on long-distance flights more than I used to. Is that actionable? There's not really a medical recommendation for something to do with this, but I like knowing that information. And people in my family who might end up on birth control pills or might have other medical conditions might like knowing that information too. As you know, this has caused a fair amount of tension with the FDA and remains controversial, but not as controversial today as when it was launched in 2007. We got funded by NHGRI to actually do an in-depth evaluation of this as a kind of natural experiment in incidental findings, because nobody knows all the stuff they're going to get from these companies. So we actually have been surveying customers of these two direct-to-consumer companies right after they give their sample, but before they give their results, shortly after they receive the results, and 6 months after they receive the results. We've just gotten the results back on almost 2,000 people. I'm really excited about telling you how this turns out, but I can only show you a few snapshots today because we've just gotten this. But I thought you'd be interested to know that these people really want to share their results. Almost 100% of them plan to talk, or actually have talked to their friends and family about their genetic results. Quite a few of them have talked to their colleagues at work. I'm just sort of imagining all of you going back to your offices and saying, hey, did you hear what my SNP features were today? What are yours? And for those of us in genetics and genomics, I'm afraid there's no love whatsoever, because the folks really aren't going to consult us. They just don't feel the need, or we're not accessible, or they're not enough of us. This industry there's been a great concern because, as Dr. Johnson suggested, you can whip up a lot of need for physicians that might not be medically necessary. And there's been a concern that this will stimulate calls to the doctor, laboratory follow-up tests that would really break the bank. So we actually have been tracking what these folks did with their information, and 27% of them within 6 months had discussed their results with their primary care docs. And in fact, 10% of them had already had tests, exams, or procedures due to genetic information. Now, I'm not sure if this strikes you as a small number or a big number. Yesterday, I was with a bunch of payers, Blue Cross Blue Shield and other large payers executives, and I was sort of representing this as a small number, and they quickly corrected, and they said 10% is huge if this becomes a large phenomenon. And we know that close to 500,000 individuals have purchased these services so far. It's supposed to be 1 million by the end of this year. So this is something we have to think about as genetic information filters out into the general population. Now, what we're really here today talking about is sequencing. I wanted to show you that because it helps understand the context of the research that our group is bringing to the sequencing question. And the reason I guess that we're here in part is because we were funded 18 months ago on something called the MedSeq project, which is one of the 6 or 8 clinical sequencing exploratory research grants that NIH has funded. And ours involves these teams, including Boston Children's Hospital, and is exploring the integration of whole genome sequencing into the practice of medicine. And we're taking 2 distinct groups because we think sequencing is very different depending on whether you're approaching a patient with an illness or you're approaching a healthy individual. And in our study, we're taking folks who have a hereditary cardiomyopathy, and we're taking middle-aged adults who are basically healthy. And we're putting them through what is essentially a REVEAL study on steroids. We're putting them through a randomized clinical trial here where they get a standardized family history versus a standardized family history and the results of whole genome sequencing. Same thing on the disease-specific side with the cardiomyopathy patients. And we're enrolling both the physicians and the patients as participants, so we're studying both. Now, we didn't want people just to sort of refer these folks to genetics, much as we like the referrals, so we're discouraging referral, but we do have a safety net here called the Genome Resource Center. They can call or email 24/7 if they feel like they're in trouble, and we have lots of safety features built in, including a real-time medical record review to see what these doctors are doing with genomic information in real time with real patients. Now, you might say, well, how the heck do you communicate the results of the genome sequencing to the doctor? And you're right, that's a huge challenge because, as you know, and as David was alluding to, there's lots and lots of variants discovered, and they get filtered by frequency, by family segregation, by what kind of protein they make. And then out of that, in any given situation, you get a smaller number of variants that are still confusing. You still have to manually curate these. And the laboratory at Boston Children's Hospital is expert in doing this. The laboratory of molecular medicine is expert at doing this. This is a manual curation step, which, if you're lucky, comes up with a couple of causative variants. And we are using that kind of pipeline. To generate likely pathogenic and pathogenic variants and then put these in a general genome report. Now, with Heidi Rehm in this study, we've generated a 1-page report. This 1-page report, if you think about taking all 3 billion letters of the genome and putting it in a 1-page report, it's a pretty fantastic operation. And in this report, we've got one segment here which produces monogenic disease results. This is an example. Any given person would likely not have one of these, but maybe 1 in 50 or 1 in 100 people might have one in these. Then there's a second section, which is a carrier risk report. A third section, which is, am I doing this? Which is a pharmacogenomic report. And there's many pharmacogenomic pieces that you can have. Okay, thank you. And a blood group report. And so we've got other parts of the report that are in more detail, but the idea is that we orient a primary care physician to these reports, just like you get oriented to reading an X-ray report. And then we give them this report and let them loose on the patients. And we're following patient behaviors and healthcare utilization by the doctors, physician decision-making, and cost effectiveness. Now, most relevant to the children's hospital arena and to many of your interests, there is a question about should newborns be sequenced? I mean, if you think that the sequence provides you with valuable medical information that you can tap for the entire lifetime of a human being, then why not perform this sequencing as early as possible and have it for physicians to use? And indeed, everyone from everyone from Francis Collins to Guttmacher to many, many visionaries and futurists predict that this is the wave of the future, that there's simply no stopping it. And if we don't get on board as medical practitioners and understand how to do this appropriately and safely, we will simply become irrelevant as people in society demand this for their children and themselves. We've actually done a survey which shows that new parents are extremely interested in receiving genomic screening. And they remain interested even 3 months after the psychological stress of giving birth, and even when they're given mock results demonstrating the complexity and ambiguity of this information. So what about it? Do you guys want to sequence your newborn babies and have that information for the rest of their lives? Well, I'm very excited to tell you that we just learned with Alan Beggs as one of the multiple PIs and myself that we have just been funded on a separate U award to study this in newborn babies and using babies from the NICU at Boston Children's Hospital and healthy babies from the ward at Brigham and Women's Hospital. And we hope to give you some answers to that in years to come. I'm just going to finish up just with 3 slides on the incidental finding question, because many of you have been involved in issues. Incidental findings is one of the most distressing problems in the whole arena of genomics, because as you've heard and as you've gathered, we can test you for one thing using the whole genome. It's going to become cheaper and faster and easier to do that. But it's just as easy to get information on the other 19,000 genes that are in your... And there's still a lot of controversy about this. Part of the controversy is what is the right analogy here? If Dr. Johnson looks very fit and he falls off his mountain bike and comes into the emergency room and we put up a chest x-ray to check and see if he's got a broken rib, and we see a spot in his lung, the radiologist has a fiduciary duty to observe that incidental finding and report it back to his doctor so that if there's something bad there, they can look into it. That's an expected part of the practice of medicine. But the real question is, when you do a genome, are you doing a test of one gene and the other 19,000 so forth are irrelevant, and you can actually block them, which you can, or is it a test of 20,000 genes? And any important incidental finding ought to be observed and reported. So I'm going to skip this and go right to the recommendations that we put forward. They have remained a little controversial. They basically say that these 24 rare conditions should be looked for in a molecular lab every time an exome or genome is sequenced and reported back to the physician. They're particularly controversial because we said they should be reported back whether the patient has requested them or not. That has struck many people as violating patient autonomy. And indeed, many labs have decided to make this sort of an opt-in, opt-out. But we have reasons for thinking that this converges with current medical practice. We've gotten a lot of criticism on this. We've defended these positions, and you can read all that. I'm happy to send you these various papers if you're interested. So my final slide is that even though evidence is insufficient, and it is, and it will be, because with every year that passes, the more we'll understand, but there'll be more exciting stuff that's on the cutting edge. So we'll always be dealing with insufficient evidence. Clinicians are still going to have to provide advice, patients are going to have to make choices, and policymakers must establish policies. I want to thank these many teams that have collaborated on the REVEAL study, the personal genomics study, the MedSeq project with its now close to 46 collaborators, and the newborn BabySeq project examining the impact of newborn sequencing in the practice of medicine. Thank you very much.
Thank you. Years ago, when I got my first job as a hospital staff physician in Boston, an elderly research physician who trained in Austria stopped me as I was making rounds and introduced himself. He spoke with a strong Austrian-German accent and said, "Herr Dr. Feingold, to be medically successful in Boston, there are two things you need to do. You must dress British but think Yiddish." I was recalling this advice because our next speaker is the complete antithesis of this. I first met Dr. Jeff Murray when he was a medical student. He was wearing jeans, a shirt not tucked in, and a scruffy beard. After his Boston training, Jeff settled in Iowa, where he continued to wear jeans, shirt not tucked in, and a less scruffy beard. Although we in Boston would consider him to be sartorially challenged, in Iowa no one seemed to care. But in spite of his sartorial deficiencies of not dressing British, or maybe because of it, Jeff has had a career that makes this old mentor of his very, very proud. He has published over 400 peer-reviewed articles, has his own research laboratory, has research projects, now listen to this, in Argentina, Brazil, the Philippines, Thailand, India, Denmark, Norway, and Japan. He is also the present president of the American Society of Human Genetics and finds time to even see patients and also to be a loving grandfather. So it gives me great pleasure to introduce a more Boston-dressed Dr. Jeff Murray.
So everything that he said is pretty much true. I did dress better today for the new CEO so that I wouldn't embarrass her in any way. So David and Robert have done a really great job of sort of presaging some of the talk that I'm about to give. And then Dr. Johnson's, I think, really set the sort of framework for the discussion that we'll have after the talks are finished. And I will probably come back to this at the end very briefly, but I actually can't thank Dr. Feingold enough. Everything that I've been able to do in my career is a result of what I learned from him initially as a medical student. He really inspired me to go into genetics, and I think he absolutely is the person who taught me that the patient that's in front of you at that moment is the most important person in the world. And he demonstrated that then, and he continues to demonstrate it now. And part of the reason that we're here is in follow-up to the kinds of work that he's done with patients for so many years. I also remember, since I was also a resident under him, that he was also the one staff person who would call you at 5 minutes after 3 in the morning when the hemoglobin had been ordered for 3 a.m. to ask you what the hemoglobin result was. And so he really demonstrates an unbelievable level of patient care, and the Genesis Fund is such a worthy project and really allows that legacy to continue today. So we've seen sort of slides like this before, so when I was putting this together, I noticed that just last week there were 2 other similar kinds of presentations in Boston, one on prenatal molecular diagnostics, and then one on something called Consumer Genetics Conference, both of these in the last week. Actually, raise your hand if any of you went to either of those 2 conferences. So I guess at least a couple of you did. And coming up later this month, there's going to be the World Congress of Psychiatric Genetics and the American Society of Human Genetics meetings here. If you didn't want to be in Boston today to learn about genetics, as all of us are, you could have been on the upper right there. You could have been in San Francisco, which has a way worse baseball team and a way worse football team than Boston does, but has some other amenities that people like, I guess. So these are the kind of things that I'm going to go over. So I really want to have this have a public health underpinning. And again, Robert's done a really good job of leading into this. I'll talk about education in a few different ways. I'm going to really, I hope, complement what he just talked about in terms of direct-to-consumer testing. I'll talk a tiny bit about fetal sequencing from maternal serum, which is technology that may allow us to do newborn screening even before the baby's born, and then a tiny bit about where we're going to be going next on all of this. So I put this in just to make a couple of points that in each generation, we're challenged by the technologies that we have at the time, and the technologies are often quite controversial. As Dr. Feingold has already told us, I was alive, although I was too young to actually remember when 46 chromosomes became the norm. But I do really remember in high school in the mid-1960s that my biology teacher just thought that, like, knowing it was 46 and not 48 was like the most amazing thing ever, that we finally really knew that number. In the 60s and 70s, newborn screening and prenatal testing became widely available, and I'll talk in a little bit about newborn screening as this sort of paradigm for public health models. Gene mapping in the 80s and gene finding in the 90s, again, have been very controversial at the time that they were done, both because of the perceived expense of undertaking the research technologies behind these, and then later on through things like issues related to gene patenting, which has had a lot of resonance recently with the Supreme Court decision over the myriad BRCA1 and BRCA2 mutation marketing. And then, as we've already heard about, the 2000s and next generation sequencing. I did want to make a point. We've all talked about genomes a lot, and I want you to sort of keep in mind that there's at least 4 genomes that you probably need to think about, not just the genome. So there's the genome that all of us share as humans. That's the kind of reference genome that we talk about, and that's where there's these 3 billion letters, but tens of millions of differences between you and the person sitting next to you. Each of us has our own individual genome that's given to you at conception, coming from your mom and your dad. Then we're also increasingly recognizing that there is this somatic genome, that our genome changes over time. Different cell lines, different organs, different systems have changes in their DNA sequence. So that's an important thing to think, that it's not static in some sense. And then finally, we have a metagenome, which is the genome that we share with all of the microorganisms that live in or on us. And although we're still a little bit of a ways away from lunch, you need to think about the fact that you have about 100 trillion microorganisms inhabiting your gut and your mouth and your skin and everywhere else in your body, and that they're happy being there for the most part, and you're happy that they're there, because they're helping your immune system function. They're probably helping you think in some ways. They're certainly helping you digest the foods that you're going to eat. And so that sort of metagenome is also something that will come into play as we talk about doing diagnostics in the future. I also want to make this point, and we'll come to sort of the deterministic aspect of genetics. And much of the conversation that we've had already today has sort of been, at least implicitly, around the space of single gene disorders. So again, as David told us, these are the ones that are caused by mutations in a single gene. They have Mendelian inheritance. They're easy to recognize if they have a known gene and a known mutation, and in fact, in probably another less than half a dozen years, the cause of almost every Mendelian disorder is likely to be known. That is the gene associated with it. And we already know, as you've heard, the technology that we have to look at this. And these are the rare sorts of disorders that are commonly seen in clinics. So the cystic fibrosis and the sickle cells and all the metabolic disorders that are seen and so on. They're ones that show up in families like this, so easy to recognize that way. A few affect what are relatively common traits like breast cancer and Alzheimer's, and I'll come back to this in a second. And then there's a very few, maybe only earwax type, where a physical trait associated with an individual actually has a single gene underlying its particular phenotypic expression. Most disorders, common disorders, have a genetic component certainly, but it's not solely caused by a single gene. There's environmental components, and as I'll talk a tiny bit about, there's epigenetics and random chance and microbiome and stuff involved in that as well. These are the common things: obesity, high blood pressure, diabetes, asthma, preterm birth, all of these kinds of things. And a handful of these also overlap over here. So I put breast cancer and Alzheimer's, which have both common complex causes, very difficult to predict, and breast cancer and Alzheimer's disease over here, which have single gene Mendelian causes and have high recurrence risks within families. And this is an important distinction, because most of the things that will show up in a primary care doc's office are going to be these kind of common complex traits over here. And although they have a genetic component, that's not one that solely things such as whole exome or whole genome sequencing is going to allow us to address. One way that we know that is through studies of identical, not really identical, but monozygotic twins. There's 3 sets of twins here. Only one pair is identical. People know which pair that is? It's the Winklevosses over here. Ashley and Mary Kate over here are actually non-identical twins. And do I want to update? No. And Arnold and Danny, of course, are not really twins at all. So for single gene disorders, identical twins are essentially 100% concordant. If one's got cystic fibrosis, the other one does. If one's going to have Huntington's, the other one does. Although age of onset for things like Huntington's and et cetera may not be identical in those identical twins. But for common disorders, the hypertensions, the obesities, the asthmas, et cetera, if you lump all of those together, if one twin in a monozygotic pair presents with that, the chance that the other twin will also develop that same disorder is only on the order of 10 or 20%. Massively increased over what the population risk is for whatever that disorder might be, but still far less than our capacity to actually be able to predict it. So even if we have the entire genome sequence of these people, and remarkably, the Winklevosses tell us that if we know your genome sequence, we in theory can predict exactly what you're going to look like, how tall you are, your eye color, your skin color, et cetera, so that you're physically indistinguishable. We won't get to a point where from the sequence only, we can completely predict all of the health outcomes in a particular individual. Even twins who certainly share many environmental characteristics growing up, still only are going to have this kind of a concordance for complex traits. So as we see our patients in the clinic, and certainly as they're doing the current level of 23andMe tests, most things are going to fall in here, and we have to remind ourselves of those predictions as we talk with people. The public health aspects of genetics probably began many, many years ago, but I like to think of it as beginning with Rh testing. So Rh incompatibility between a mother and a fetus, which can lead to hyperbilirubinemia and significant jaundice, and in the old days, certainly even death, is due to this genetic incompatibility between a mother who's Rh negative and her infant who is Rh positive, having inherited that from the dad. And that kind of screening began to be applied in the late 1940s and 50s when we could begin to predict outcomes, provide better treatments for the newborn infant, and eventually actually even do in utero therapies, and eventually through things like RhoGAM prevent it, so we could prevent the occurrence of a genetic disease. Newborn screening is a particularly apt model, and Massachusetts and Boston Children's in particular has played major leadership roles in developing a better understanding of how to apply screening to newborns. Mostly looking for rare disorders, but ones that we know that if they're identified early on, we can prevent horrible outcomes, mortality, severe mental retardation. And this is an enormous success. More than 99% of newborns in the US are screened for this each year, and literally tens of thousands of lives have been improved just in the last decade. And we're getting better and better at doing more and more of this screening. And again, as we just heard from Robert, there may now be the opportunity to do this at the DNA sequencing level as well, since most newborn screening is detecting disorders that have a genetic component. We're increasingly using physically oriented screening, hearing tests, congenital heart disease screening, which can detect disorders which don't have a single gene cause, but nonetheless, most of the things that have been detected historically and that we screen for now fall into this area. And of course, we all have undergone, as adults, things like cholesterol or glucose or drug screening or many other population-based screening as well. So how this is going to be applied now, once DNA sequencing becomes accessible through both cost and access, is going to be an important question. Education. We haven't talked, this has been alluded to a little bit, but education, as Robert's talked about, is really critical for not only healthcare professionals, all the people who belong in these groups down here, primary care docs, physician's assistants, nurse practitioners, nurses, social workers, RTs, all the people who come in contact with patients. But it probably needs to begin even earlier than that with consumer education. Genetics is both very complex, we all know that from listening to people today, but it's also very, very accessible and understandable to anybody. It has some simple rules, certainly in the Mendelian cases. It's all around us. People observe their families. They observe physical traits that have been inherited. They observe familial diseases, diabetes, asthma, et cetera, that run in families. So it's an easy conversation to have with people. But the last education that people get formally in genetics usually occurs in the 9th or 10th grade, which is when 95% of the population has their last contact with biology or genetics. After 10th grade, hardly anybody is going to have formal education again. And there's an enormous importance behind both evolutionary teaching and genetic teaching specifically that could give people the underpinnings of being able to better understand genetic disorders, how and why they occur. We particularly probably need to put emphasis on things like numeracy. People don't really understand numbers. When you tell a patient that they have a 5% chance that their next child is going to have the same thing that their first child had, or a 25% chance, people interpret those numbers very, very differently. That can certainly be appropriate to their own situation, but people also don't have a good sense for what even something like a percent means. And similarly, risk assessment is also something that people have a hard time with, at least when it comes down to talking about genetic risks. High school students take risks all the time. They drink, they drive, they ask somebody out and get rejected. They're very used to making assessments about risks in their lives, and we need to incorporate that in a way in which they can also have a way in which they see how that applies to their life from a health perspective as well. Health professionals, again, this education certainly needs to be all across people who have point of care contact with patients. All of these people here will get asked questions about genetic and genetic risks, and they need to be at least conversant and fluent with it. As we've heard, there's not enough geneticists and genetic counselors, nor will there ever be, to have one sitting in every primary care doc's office. So these people need to have a good understanding of what's going on. And then the professional organizations, the College of Medical Genetics, basic science societies, genetic counselors, nurses, coalitions of professionals, and even groups that do undergraduate education all need to work together to provide consistent messages for their membership, and also to do a better job of teaching through continuing education people who have already escaped the training programs. For myself, probably the biggest impact I've ever had on teaching about genetics isn't in the 150 med students that I lecture to every year, or the 3 medical students who are in the NICU when I'm on rotation and I talk about genetics. It's having worked in the 80s and 90s with the Biological Sciences Curricula Study Group, who generated textual material around human genetics that went into all of the 50,000 high schools in the United States, and so exposed many, many students to at least some of the initial components of thinking about genetics and human genetics. Lee Hood came up with this acronym of the P4 of the personal genome, that it should be predictive of your own specific risks, preventive, that you can do something about it, personalized, that it's yours, and participatory, and that you have access to it. This is from our hospital records. Patients can get access to their medical records, and as we've heard, and I'll briefly show, the 23andMe experience alludes to this as well. People really are much more engaged in their own individual health care, and we need to both take advantage of that and provide them with the genetic components of that that may be useful to them, or at least of interest to them. As Robert told us, and I'm going to go through this really quickly because he's done a good job on this already, the DCT people, the direct-to-consumer marketing people know that this is very attractive to consumers, particularly for things like ancestry determination, medical risks in adoptees, social and genetic networking, but again, this enormous interest around individual genetic risks and risk magnitudes. And since he showed his genome, I'll show part of mine, also from 23andMe. You can't read mine so well, but I'll just make a couple of points to fill in on things that maybe he didn't mention. One concern about this is that for myself, for example, I have a decreased risk of basal cell carcinoma and melanoma, both of which can be induced by sun exposure. And there's a concern that people will interpret these kinds of lower risks as no risks. In my own case, I've had a basal cell removed, and my son's also had a basal cell removed. So we clearly have a risk for basal cell carcinoma. So one risk associated with this is that you don't want people to interpret lower risks as no risks. And then 23andMe and some of the other companies, again, as you heard, 500,000 people already, also afford you the opportunity to identify relatives who might be in their databases. This is extraordinarily reliable for close relatives like siblings and half-siblings and even first cousins. And there may be risks there in people having inadvertent disclosure of relatives that they were unaware that they had, half-siblings that their parents might not have told them about, for example. Okay, the last sort of science thing that I'll reflect on is this idea of fetal DNA sequencing. Again, Robert's already talked about this very exciting prospect for doing genome sequencing on newborns. In the last year or so, there's been several reports of taking serum from a mother, so non-invasively sampling a mother with a blood sample. The serum in mothers beginning at about the 10th week of gestation contains between 5 and 15% of the free DNA floating in that serum actually comes from the fetus. There's also fetal cells present in the mother and mother cells present in the fetus. And you can extract that DNA from the fetus. If you have the mother's genome as a reference sequence, which is also pretty easily to get, you can derive the fetal sequence from that. And some of these early studies were enabled by existing biorepositories that have stored samples on these. We participated in this study that was led by Jay Shandur's group at University of Washington. And were able to successfully sequence a couple of fetuses, verify that that was their sequence after they were born from blood samples taken from them as infants and compared to the mother and the father. As you've heard, you can find lots of new mutations when you identify this. This can potentially provide this complete gene catalog of risks that will enable you to not only identify things for the future, but all of the newborn screening kinds of things that I alluded to before. So you don't have to wait just for the baby to be born. You can actually predict what their newborn screen is going to be months before it's born, potentially preparing the families for metabolic interventions that might need to be done, other kinds of tests that might be useful in the newborn, again, as Robert said, and so on. In one of the original studies that was presented, they even published an incidental finding of a mutation in a gene of unknown consequence, but a gene that's been associated with Parkinson's. So again, reflecting or raising this issue around whether these incidental findings should be reported back to families. What are the rights of that newborn infant to know or not know that information? And again, I think in the discussion we'll have lots of time to talk about that. So in summary, we absolutely need a more educated populace, and certainly informed healthcare workers and the professional societies need to play an important role in this. There needs to be ongoing policy discussion. Robert was very self-deprecating in the amount of controversy that his article generated. There was like a whole flurry of stuff going back and forth on the web for weeks and so on afterward. But it's really wonderful that he's a really critical part of that conversation. As I said, the direct-to-consumer testing people, it's out there. Anybody can do it. We actually did this on a class of 18-year-olds in Iowa last year, and just reflecting on what Robert said, one of the young women in our group that was tested after all the consents were done and stuff turned out to be factor V Leiden positive, and she was also on birth control pills, so a finding of potential importance. And then I finally want to make just one last point, and maybe Dr. Johnson will reflect on this. We've talked a lot about the U.S. and the U.S. healthcare system. I make this point only because it's something that I see in one of the other lives that I live where these technologies are enormously expensive. This is one of several dozen little babies that I saw die from neonatal tetanus in the Philippines back in the 1980s and 1990s. The cost of the fetal genome sequence that we did would provide immunizations for enough infants that you would save 50 lives through the cost of that sequencing through immunization programs. At the time that I took this photo, there were about 800,000 infants a year dying of neonatal tetanus in the world. 0 in the United States, so we don't ever hear about it here. But all of those infants were loved just as much by their mothers as any infant born here. That number's now down to about 50,000 a year deaths, about 50,000 deaths last year. And of course, there's many, many other problems in low and middle income countries, but something for us to reflect on as we use these increasingly expensive and increasingly targeted technologies. And I just want to thank again Dr. Feingold, who's really made any career that I've had for myself. And then I want to thank my wife, my 3 kids, and our granddaughter. And this child here, who Dr. Feingold would describe as having a prominent forehead and a tented upper lip and proximal limb shortening and central obesity and looking mildly hypotonic, was this pediatric ENT fellow at Boston Children's last year. So even though his father's research hasn't contributed anything to cleft lip and palate, at least my offspring has. So thank you for taking him under your wing. Oh, and he was born across the street at the old Lying In Hospital and was in the Boston Children's intensive care unit when he was 6 months old.
And look at him now. Well, that ends our first part. We're going to have a question and answer panel discussion, which will be led by Charlie Gibson. And you all have cards. So as you leave or just stand, please give your cards with questions so we can try and answer your questions. We're finishing pretty much on time. This is just a sort of a 10-minute get up and stretch or go to the potty if you need. But be back by 11:30, and we'll start in again with the panel discussion.